Thank you, Jack, and thank you all for being here, both alive in the room as well as online. Hopefully you're alive. In speaking with a number of you today, this is your first venture out. And so I think it's a real testament to Jack and Artie that they are able to lure you to learn, which is great. So I'm going to be trying to dissect this issue of what the heck is axial psoriatic arthritis. Is it different from axial spondyloarthritis? We're going to do some term definition there. And then what are some of the controversies about management that are emerging? This is where I work. In the foreground, these whitish buildings are Swedish Medical Center, which is in turn part of a larger system called Providence St. Joseph Health. And I get to play in the sandbox of research for the whole Providence system and epic data mining and so on. So it's been a great relationship. You're looking out to the west, and of course the beautiful Olympic Mountains are covered in clouds, so you can't see them. And we're looking out toward the Pacific there. These are my disclosures. We're going to start with the case and then a multiple choice question. 45-year-old male with 10-year history of psoriasis and 2-year history of psoriatic arthritis, manifest by oligoarticular peripheral arthritis, single-digit dactylitis, and lateral epicondylar pain. He's been on methotrexate monotherapy. Over the last 3 months, he's been having back pain that started with an overly vigorous tree planting episode, but it's persisted. His initial lab work and initial x-rays are unrevealing. CRP normal, B27 negative, lumbar spine x-ray shows, quote, degenerative change, pretty consistent with a 45-year-old. So here is your polling question. To try to detect if axial PsA is active in addition to evident degenerative spine disease, what diagnosis or treatment approach would you try next? Okay. It's spread between doing more diagnostic work, either a pelvis x-ray and then MRI or lumbar MRI. Interestingly, nobody wants to throw a biologic at him and just see what happens. You're restrained. Good for you. So here we have a patient, a photograph in the middle with psoriasis and bent forward due to spine disease. In the Venn diagram circle, about 40% of patients taking all trials, studies together, patients with PsA end up having evidence of axial disease related to psoriatic arthritis. And I'm going to show you a little bit more about imaging in a moment. So there are some key differences between axial PsA and axial SpA. For one thing, whereas axial SpA patients have their disease by definition from the very onset of their disease, and often in their late 20s, early 30s, in psoriatic arthritis, oftentimes the patient doesn't have spine disease as part of their manifestation, but may develop it over time. And so you're not really getting to see the disease manifest until the patient is in an age range where it's going to be more difficult to sort out from degenerative arthritis. There's some key clinical differences that have been summarized in this great series of work by Joy Feld when she was working with Daphne Gladman as a fellow in Toronto, and now she's back in Israel. But some key points. One is that we've been taught that inflammatory back pain questions, like the pain getting better with exercise or waking the patient in the middle of the night, may not apply in axial PsA. The disease may be relatively silent, or the patient won't correspond to these questions exactly. There may be no sacroiliitis at all, or if present, it may be asymmetric, depending upon their genetic makeup. They often have very active peripheral disease, and the spinal aspect is a minor player. And so that is very different from the features noted on the right-hand side of male predominant, younger age, et cetera, of axial spondyloarthritis. Here's an example of a pelvis X-ray with quite asymmetric involvement of the SI joint, this patient's left being severely involved, and on the right, completely clean. And in the lower aspect of this lateral view of the lumbar X-ray, we see these flowery syndesmophytes. They're called chunky, non-marginal, that is more characteristic of PsA, whereas in the upper part of this picture, you see the more hugging, marginal syndesmophytes that are more characteristic of AS. This is also displayed here, where on the right-hand side, we're showing evidence of bilateral, every vertebral level is involved in ankylosing spondylitis, where on the left, there's skip areas, and it's often unilateral. The genetics can be different as well. About 20 to 30% of patients with psoriatic arthritis will be B27 positive if they have axial disease, closer to 85 to 90% on the axial SPA side. And there are also a sprinkling of other genes that are different between the two conditions, including this HLA-B8 that's characteristic on many patients with axial PsA and is often associated with asymmetry of disease presentation. One of the questions that arises is, who are these people with axial PsA, and does it make a difference in their overall presentation, severity of disease, and so forth? This is an exercise that we did in what was then called the Corona Registry. It's now called the Core Evitas Registry. What you can see here is that in every way that you can look at the patient, those that have axial involvement as part of their PsA have worse disease than those patients who have PsA without axial PsA. So, for example, more in the way of joint involvement, enthesitis involvement, skin involvement, less likelihood of achieving minimal disease activity with treatment. And so it's a biomarker, if you will, of more severe disease activity. So what is missing from what I've presented to you so far is key data that you can derive from biopsies of tissue. So I don't know many patients that really are going to embrace our coming at them with a needle and going into their vertebral bones or entheses or the posterior joints, for example, and getting biopsy material. It's been done a bit, but it's rare and far between. So we're really missing a lot of information about the immunobiology that can help us with the distinction between these two conditions. Launching into a discussion about treatment, let's start with a case. This is a 53-year-old female with a 10-year history of psoriatic arthritis, which has, again, mostly peripheral manifestations and skin disease when it flares. She's been cycling through a number of different treatments, going through 3 different TNF inhibitors, Guselkumab, an IL-17 inhibitor, Ixekizumab, each time with initially good response and then losing response. And she's got a bunch of comorbidities consistent with PsA. And in the past 6 months, she has developed persistent back pain, which does have characteristics of inflammatory back pain. Her pelvis MRI is normal, but a lumbar MRI shows several vertebral bodies with romanous lesions that are felt by the radiologist to be consistent with spondyloarthritis. And I'll tell you that where I work, there's a particular radiologist that I work really closely with, and he's been through the Walter Maksimowicz mill already, learning about how to read these cases. We did 40 cases in the classic study together and went through in detail. And so he's very sensitized to how to look for this in the patients that we send in for MRI scanning. So here's the question. After Guselkumab, which is the last in this cycle, which agent might you next choose? Severity, a JAK inhibitor, an IL-23 inhibitor, or a different TNF inhibitor? I'll tell you right now, there's no exactly right answer. You may have different preferences here. Okay, let's take a look at the results. Interesting. Okay, so even in this patient with cardiovascular risk, et cetera, okay. So it's clear that what you're wanting to do is move to a different mechanism of action, and one that has known efficacy in spondyloarthritis, as evidenced by the positive data that we've seen from tofacitinib and upadacitinib trials in ankylosing spondylitis. Secukinumab is second, it looks like, although it just looked like it shrunk a little bit there. And then some of you would actually choose an IL-23 inhibitor, and some would go back to trying a different TNF inhibitor. So it looks like there's a range of choices here. Here is the evidence. I already earlier talked to you about the treatment recommendations that have been forthcoming. This is from the 2021 treatment recommendations from the GRAPPA group. And here I'm focusing in on the axial arthritis aspect. And it's divided into those that are biologic naive or biologic experienced. And so what you see in the first box are all the different approaches that have shown efficacy in at least ankylosing spondylitis trials, and in some instances non-radiographic axial SPA trials. So we've got NSAIDs, physiotherapy, analgesia, simple analgesia, TNF inhibitors, IL-17 inhibitors, and JAK inhibitors. So that supports the choices that you've just been making in relation to the patient we just saw. And the same is true for biologic and adequate responding population. If we go over toward the right, we can see that there's a strong recommendation against CSD-MARDs, such as methotrexate or sulfasalazine, and that's because we just haven't, in ankylosing spondylitis, ever shown efficacy of those drugs compared to placebo in spinal aspects of the disease. There's a bit of evidence in AnkSpond that sulfasalazine can help peripheral manifestations, but not spinal manifestations. And then on the far right, there's this group that's no recommendation, insufficient evidence, and we're going to explore this a little bit. And you might wonder, well, gee, if IL-23 inhibitor therapy is just a bit upstream from IL-17 inhibitor therapy, why shouldn't it work? And we're going to get into this. So here is data from the only trial that has been dedicated to Axial PsA to date. All of the other data that went into the evidence base for the TNF inhibitors, the JAK inhibitors, et cetera, has been extrapolated from ankylosing spondylitis trials or non-radiographic axial SPA trials. So the way this maximized study was done was that about 500 patients were entered. The key point was whether the investigator thought they had axial PsA or not. Now that could have been based on them knowing something about the history of the patient. It could have been based on previous imaging that had been done, etc. But that was the basis for it. There was not a requirement for an imaging inclusion criteria. Imaging was done, and it was done throughout the trial, MRI scanning and so forth, but you didn't have, like you do with most AxSpA trials, where there was you would determine the entry based on the findings of either sacroiliac abnormalities or spinal abnormalities consistent with spondylitis. So all of these patients launched into the trial, and it turns out that they actually kind of, just on face value, they fit. Somewhere between 20 and 30% were B27 positive. They all had back pain. They all had significant back pain in order to get into the trial. And so it was a believable population. And as you can see, the ASAS-20 response at the end of 12 weeks was somewhat similar to what we've seen in secukinumab trials in ankylosing spondylitis. It works, and clearly separated from placebo. What was fascinating is that only about 60% of the patients that entered the trial and went on through it had MRI abnormalities consistent with spondylitis. 40% did not. Yet when you looked at the results, not only did the MRI positive patients have the kind of improvements that we would expect in both the spine and the joints from an effective therapy, but the MRI positive and MRI negative patients also responded similarly. So it looks like the drug works, regardless of whether they're MRI positive or not. But a challenge to us who are in the process of developing a classification criteria for axial PsA is, how do we include these patients that end up being MRI negative into a classification schema? That's going to be, I don't have an answer for that. That's going to be a challenge. But I think it bespeaks the fact that there is a group of patients with PsA who may not have what we tend to depend on as objective evidence for inflammation in the spine. So one of the reasons why spine disease has not been as thoroughly assessed in our phase 3 trials of psoriatic arthritis is for several reasons. One, because this is only a subset of the patients in a trial, 30%, for example, maybe, that group is not powered to give us an answer about response in the spine. It would require doing serial imaging, including MRI, which is going to be expensive to do. And with drugs that are going to go through an ankylosing spondylitis approval anyway, such as the TNF inhibitors did, or the JAK inhibitors, or the IL-17s, why go to all that trouble? Just use that ankylosing spondylitis data as a surrogate for thinking that the drugs are going to be effective in axial PsA. They're close enough, why not? And your own clinical experience would support that. However, as you'll see in a moment, this doesn't always work. And so we need to do, I think, increasingly we need to understand, are there some key differences between the Axial PsA group of patients that may portend different responses to treatment? Now, one way around doing a formal trial has been to throw a BASDI measure into the mix. But there's challenges with that. The BASDI was really only created for measurement of response, of disease activity and response in ankylosing spondylitis, or the broader field of axial SpA. And many of the questions are nonspecific enough that they can, if you have a patient with very active peripheral disease, they're going to have a high BASDI, and it may respond to treatment just based on peripheral improvement. Here are the 6 patient reported questions that are part of the BASDI. As you can see, they're not all axial related. Fatigue. There's question number 2, which arguably is related to the spine. Pain, swelling, and other joints. Overall discomfort from tender areas, that includes enthesitis. And then 2 questions about morning stiffness, which is a surrogate for inflammation. So here's a key study that was done in a group of 5 centers. Soumya Reddy at NYU was the lead author. Alexis Ogdi at Penn, who you heard from earlier today, was the senior author. And they asked the question amongst 117 patients with PsA, some of whom had axial disease that was determined, and others who did not. And at baseline and after treatment, they looked at responses and found that there was no difference between those that had spine disease and those who didn't. So this really, unfortunately, impugns use of the BASDI as a surrogate in these trials. So then we come to, we've already established that we've got several drugs that have shown good efficacy in AXPON. We've got the Guselkumab data and Axial PsA. Now we come to the IL-23 pathway. And this is an older slide that shows that IL-23 is key in turning on or stimulating Th17 cells to produce IL-17 and so forth, so it's considered to be upstream from IL-17, so shouldn't it work? Here we have the results of a small phase 2 trial in ankylosing spondylitis with Guselkumab, which is a P19 IL-23 inhibitor. Completely flat, no difference from placebo. Here we have a trial with Guselkumab. This was actually a surprise because there was a 20-patient open-label study done in Germany that appeared to show great response to Guselkumab in ankylosing spondylitis. Here is a trial in ankylosing spondylitis, big phase 3 study, which showed no difference from placebo. So this led to several of us being asked to write editorials about why we thought that IL-23 inhibition didn't work. And so there were a number of different ideas besides vagaries about the patient population that were potentially an issue, including the fact that IL-17 could be present in the spine and regardless of any IL-23 stimulation. So other sources of IL-17 coming from resident immune cells. That there were differences in IL-23 secreting myeloid cells in the spine compared to peripheral sites. So a basic immunobiologic difference might be present. There might be a difference in, quote, tissue cytokine hierarchy, with some cytokines being more important than others in depending upon the domain that you're looking at. Differences in one pathology being more bone related and not as much enthesial related. So various ideas were thrown out there. Here's from work by Stefan Siebert in the Glasgow group suggesting that there are different important cytokines in these different tissues that are part of PsA. But wait, here we have an interesting sub-analysis of the Discover 1 and 2 trials with another P19 IL-23 inhibitor, Guselkumab. And in this particular trial, what was done was to have the investigators identify the patients they thought had axial PsA at the outset, and then they had to have evidence of, if you look at the first bullet underneath the table here, They had to have evidence of sacroiliac changes either on an X-ray that was locally read, mind you, or an MRI scan. So some evidence that there had been some sacroiliac problem, presumably inflammation leading to the appearance of sacroiliitis. So that objective marker combined with the investigator. And again, this looked to be a pretty characteristic group. About 20 to 30% of the patients were HLA-B27 positive. It overall was 30% of the two phase 3 trials. So that fit with what we know about the epidemiology of axial PsA. So it seemed to fit. And they all had high spine pain at the outset. So here are the results using BASTI scores. And as you can see, there was statistical separation between treatment groups and placebo, 2 different dose arms of Guselkumab. And that was sustained out through week 52. And even when you looked at just the spinal pain question, there seemed to be a difference. And a modified BASTI where they took out the joint question, peripheral joint question. Using a slightly more objective measure, the ASDAS score, there was also clear-cut improvement, including what we call ASDAS in active disease. So for all intents and purposes, it looks like this drug actually helps at least the symptoms in axial PsA. Is this the end of the story? No, it's not. As noted in the second bullet, Janssen is proceeding ahead with a specific trial in axial PsA. It'll be a big trial. And in order to get into the study, the patients are going to have MRI evidence of abnormalities of either the sacroiliac joints or spine in order to be part of the study. And this will give us, hopefully, with all the bells and whistles of serial MRI scans and so on, this will give us a more definitive answer about this question. In parallel, the ASAS and GRAPPA groups are in the process of developing a classification criteria to better harmonize, homogenize who it is that we want to be studying when we're doing clinical studies. And another independent investigator study that a number of us are involved in is to try to molecularly characterize differences between those patients with axial PsA versus PsA, and then in the future to molecularly distinguish from axial SpA. So all of this is proceeding to try to help us along the way here. So this is my last slide. So here are just some little pointers about dealing with the axial PsA question in the clinic. So the first step is, of course, ask, talk. Is spine pain present? Try to take a little bit of time to discern whether it's inflammatory or not. Consider examining spine flexibility with your measuring tape. And if you're at all suspicious, image, starting with X-ray and proceeding to MRI. And it's great if you can have a good radiologist to partner with for your, as you look at the images together on the screen to see whether or not the patient really has active inflammation. You can check an HLA-B27, but note that the minority are going to be positive. Do your best to try to discriminate between degenerative spine disease, fibromyalgia, and inflammatory spine disease. And then, although it looks like none of you would ever do this, based on the responses to the first question, sometimes we just end up having to throw a medicine at the patient that may work and see what happens. And I must admit, I've been in that boat before myself, and I've been surprised and pleased when people appear to have a good response. So I'll leave it at that, and there you go.